All right, this is everything that I learned in paramedic class today. I read the book for a good while. I want to say over 2 hours, and let's see if I retain any information. I have a class with a test on it in 6 days over airways, so that's what we're going to be focusing on. Everything airway related in terms of the anatomy of how we breathe, as well as the pathophysiology of things that can affect and maybe hinder people's airways, and interventions that can help save lives. So this is going to be a start of a series I like to call The Blind Teaching the Blind. It's probably just going to be me listening to this because I heard somewhere that teaching is the best form of learning, and I want to get in on that by teaching. But I am also very inexperienced, and I don't feel I don't feel like I could teach someone right now what I'm learning. So I'm just gonna record myself as if I'm doing like a lecture, teaching what I learn, and maybe in a year I can look back on this and see how inexperienced and uneducated I was now, and hopefully in the future that'll change. So to start, let's talk about some pathophysiology. Let's start with emphysema. So emphysema is a late stage chronic obstructive pulmonary disease. It is categorized by a pink bubbler, or I don't know, but essentially they are pink for some reason. And on expiration, people with emphysema tend to perspire lips to extend the expiration. They do this because they something about CO2. So yeah, so emphysema is typically happens after bronchitis or chronic bronchitis. It develops into emphysema. So it is the anatomy is there is more air, more dead space in the lungs. It's caused by typically smoking is an extrinsic factor that's what you see. And what happens is, because there's more dead space in the lungs, there's not enough area for alveoli to there's not enough surface for alveoli to diffuse oxygen and carbon dioxide, because there's this dead space that's just air. Let's move on to so how do you treat someone with emphysema? Typically with COPD, their stats are going to be less than ideal. Their oxygen saturation typically is going to be less than 90 as their normal. And correcting their oxygen saturation to 100% like you would a normal person is not ideal. I also learned about the hypoxic drive, which is basically when your body runs off a carbon dioxide drive, which and when you're there's already so much carbon dioxide, your body tends to switch over to your oxygen drive. And it's said that if for prolonged periods of time giving people high flow oxygen, it can cause them their drive to go down, and they breathe less because it's because they're using their hypoxic drive, and when they see, we have all this oxygen, we don't even need to breathe, when in reality that's bad. It's also stated to not withhold oxygen for fear of triggering the hypoxic drive, you should give oxygen. So with emphysema, you want a CPAP, continuous pressure. All right, come on, you know this. What does CPAP stand for? Continuous pressure, a continuous positive air pressure. Yeah. And that's to, it's keeping pressure to open up the alveoli, because people with emphysema have less elasticity. So, and also their alveoli tend to stick together. So you'd want to open that up and keep that open. If you think of like alveoli like a ball, if it's deflated, then and it's like stuck together, there's less surface area. But if you keep it open, there's more surface area for the exchange of oxygen and carbon dioxide, so they can breathe better. In terms of positions to put the patient in, you don't want to put them supine. You want to have them in a semi-Fowler, basically sitting up. That's because when they lie back, I might be misinterpreting this for something else, but that's what I think it is. But I know that's for COPD in general. I don't know if that's exactly emphysema. But yes, let's move on to chronic bronchitis. Chronic bronchitis, I know they categorize as blue bloaters. Blue is because they are cyanotic, and which means they don't have enough oxygen, so they look blue because their blood cells are not red. Oxygen makes their blood cells look red, and when there's a lack of it, there's blue. And bloaters, I'm guessing that's edema. They get edema. And what's edema? So that's like fluid, excessive fluid. So pedal edema is excessive fluid in the feet. Why this fluid buildup is, I do not know. So asthma. Asthma is, for child asthma, it's typically an extrinsic factor, which is pollen, air quality, yada yada. Adult asthma is typically intrinsic, which is genes that are given to them get asthma. Typically with a child asthma, it goes away as they grow up. And then adult asthma obviously didn't go away because it was given to them. So asthma is characterized by bronchospasms, which I need to learn about. I don't really know, but it's sent in. They're going to be using accessory muscles. To treat someone with asthma, you're going to give albuterol as well as some other stuff that I don't really know. I know that the categorization between asthma and COPD, it's often categorized wrong. Like there's a study where like 57% of people that are pre-hospital diagnosed as COPD, when they were brought into the hospital, 57% were correct, and it was actually COPD, and then asthma was down to like 40%, which was correctly diagnosed. So that's something to think about. So breathing, if I'm going to breathe in through my nose, I'm going to breathe in through the nasal cavities, and the air goes into my nasopharynx, neopharynx, whatever it's called. It goes down into the oropharynx, and then from there it goes into whatever the space that the epiglottis is. And when it goes to the epiglottis, it goes into it goes into the larynx, and then goes into the trachea. So the larynx is below the epiglottis, and it is, I believe it cuts off at some type of cricoid cartilage. All right. Let's reset. So from the trachea is going to bisect into to the bronchioles, and it bisects at the carina. On the outside, it's the xiphoid process, which is below the sternum, and above that is something, or I think it's David's arch, which is the top of the sternum. And then, so the trachea has about 20 cartilage rings, and the rings are separated on the posterior side to allow the food to travel through the esophagus. The esophagus is posterior to the trachea. And from there, there's goes into the bronchioles separate into the secondary bronchioles, separate into the tertiary bronchioles, which separate into the terminal bronchioles, getting smaller and smaller. Bronchioles. And at the end of that, we have the alveolar ducts, which contain the alveoli, which has the exchange of oxygen, and that is called exterior. No, it's not. It's, I believe it's exterior. Whatever the word for exterior is, ventilation or exterior respiration, which is the exchange of the oxygen and carbon dioxide from the alveoli through like into the red blood cells, and those red blood cells are transported to the heart, and the heart pumps them. It goes to the heart from the pulmonary vein, and then it goes through the left side of the heart. Sorry. Oh my gosh. Goes to the aortic valve, into the tricuspid valve. I'm just naming a bunch of gibberish. I actually don't know all of that. I need to study up on that. Hopefully I will know that by tomorrow, because we have a test coming up and I need to know all this stuff. Anyways, it goes through the heart and it goes out the arteries to the tissue throughout the body, and in the tissue it gives, that's where the interior respiration happens, whatever the word for that is. And that is the exchange between the cells in the tissue with the arteries, and then those red blood cells go through veins back to the heart, which is then pumped to for the pulmonary artery to the lungs, and it goes emphysema causes damage to tissue as well, because you have a heightened state of carbon monoxide in the body. Carbon monoxide should, on expiration, should between 35 and 45 millimeters Hg, and this is typical. If it's above that, then they are hyper. If it's above that, then they are hypocapnog, and if it's below that, they are hypercap. And Maybe it's the other way around. I'm not sure. But I just know that hyper and hypo cap is the opposite of hypo and hyper acidosis, because carbon monoxide is acidic, and when you have more carbon monoxide in the body, your body is more acidic, and so you get hyper. Oh man, it's been a long day. Okay. We're at the 15-minute mark. I need water. Everybody take a water break. Water break. Water break. Water break. Water break. Water break. All right, brothers. So, talking about airway. So, just gonna do assessing. So, indications for intubation. I don't know. Contraindications? I don't know. I want to say like indications are like bronchospasms, tracheobronchial. Okay. So let's do upper airway and lower airway problems. So upper airway, we have obviously trauma, and then we have we have the laryngitis, the laryngtracheal bronchitis. Okay. The main function of the upper airway is to warm, humidify the air. Push through, bro. Push through. You got this. You got this, bro. You're going to be a paramedic in 1 year. You got this, man. You got this, dude. You got this. Come on. Come on. Just tell me what you know. All right. I know that for an average adult, respirations are going to be 12 to 20. Tidal volume, I believe, is around 2,000. Or maybe that's like 3,000. I'm not sure. But the dead space is probably going to be like about 500 milliliters. Okay. There's something I think pulmonary embolism I believe affects the something that affects the pleural space. It makes it rub, and that's bad. All right, we got 20 minutes. We're up to 20 minutes. I should probably wrap up now. Oh my gosh. Why does my head hurt so bad? It doesn't matter. We're going to push through, bro. We're going to push through. Okay. Delayed sedation measures, whatever that's called, is when you pre-oxygenate the patient before you intubate them. Intubation is, we have endotracheal intubation and oreo something. So endotracheal is, I believe that's almost done. I'm not sure. But essentially you're going to take your laryngoscope and you're going to... Okay, first you're gonna be oxygenating. You're gonna have the IJO in or a OPA MBA. You're going to take that out and you're going to pull. You're not gonna press back onto the teeth. you're going to get them up into a sniffing position, put blankets underneath, and then you're going to use the tip of the laryngoscope to basically find the epiglottis and pull up on the epiglottis. And when you do that, it's going to alright, that's good for today. But yeah, I'm going to finish what I was talking about intubation. So below the epiglottis, lift the epiglottis up, then you should basically lift to where you can see the vocal cords, or whatever the scientific name for that, and then you're going to drop your bougie and aim for the vocal cords, get in the vocal cords. Then you're going to take your ET tube and you're going to put it past the bougie and slide it all the way down, and to where the black part is just like basically in the vocal cords. We're going to inflate with 10 cc's or whatever you have. Inflate that tube. Immediately take the syringe, or take the why can I never remember the name of that? But yeah, take that off, and then you're going to you're going to, book says check the stomach first for lung sounds, but before that you're going to attach the BVM with PEEP valve set to 5, I believe, and then check the stomach first, because just to make sure you're not in the stomach. Then you're going to check all 4 of the lung planes, and then you are good to go. And as long as you don't hear any sounds in the stomach and you hear bilateral breathing, then you're going to take that. Before all that, my bad, should take the bougie out, but yeah, solid work, man. Oh, and then cricotomy, that is essentially like not protect their upper airway, and intubation is not indicated. Say they have facial trauma, or some other stuff like laryngitis. I'm gonna blow that up. What am I talking about, man? But yeah, essentially how you do it is you're going to clean the area you're gonna feel the area, feel your way between the 2 cartilages, I believe it's tracheal cartilage and the cricoid cartilage. No, the cricoid cartilage and the thyroid cartilage, I believe. Something thyroid. Anyways, feel the valley in between. You're going to cut it vertically with a syringe after you do alcohol swab, and then you're going to poke past the membrane. There should be a hole. What am I talking about? There's no hole. But yeah, you're gonna find what you need, drop down that bougie, drop down that ET tube, fill it up, and then back and we could go. And then they also got a needle. Needle cricotomy, which is the same thing, but you would use it for you would essentially put in my bad, sorry, but it's for pediatric, not very good, but yeah, you're gonna put in like an IV, and you're gonna use some sort of attachment, and Yeah, you're going to aspirate on that one. So there's no blood. All right. Well, that was very rough, but it's a start of a better future. And I believe if I keep doing these and I expose myself for how little I know, but also give credit to how much I do know, then it is going to be better, you know? Expose myself now so I don't expose it on scene and not knowing stuff and, you know, inevitably accidentally killing someone. We don't want that. Or, you know, hurting someone's train of life, you know? Make a mistake that takes years off their life when it's not necessary if I had just put the time in now and not been lazy. So, yeah, thanks for blind leading the blind. I'm sure you haven't learned anything from here, but, yeah, if I could teach anything, just work hard and get out of your head. So, yeah, thanks for coming to my little TED Talk. I'm going to pause this now and be back tomorrow with some more informative words of advice. Bye.